Hello, everyone. My name is Courtney. I'm the orthopedic navigator here for Sentara Williamsburg, and I want to welcome you to our total joint replacement preoperative education class. Now, we have a theme here at Williamsburg. It is Revolutionary Journey. Any Sentara facility that has an ortho joint program is invited to come up with a theme, and that is what was chosen by Rita Wade, who was the one that began this program. So you are beginning your revolutionary journey the moment you decided to sign up for surgery. And the reason why you most likely did it is because you've had enough with your pain and lifestyle restrictions, and you're now ready to do something revolutionary, just like they did in the Revolutionary War. You are beginning your journey to independence. Now, when it comes to being in an orthopedic program, it means that we have provided a structured and organized environment. Our nursing staff and physical therapy staff are trained on how to take care of you and the schedule of the program, so that it makes it easier for the patient while they're here. It's like smooth sailing when you're here because of this program. So what do I do as your orthopedic patient navigator? I am a major resource for you. First, I do the education, such as this. I also will review transition education when you're here in the hospital after your surgery. I'll also overlook your stay while you're here at the hospital just to make sure everything is transitioning smoothly for you. The other thing that I do is I will call you once you're at home about a week later to check in and see how things are going. Now, the other thing is when you're here, if anything's going on and they need to get a hold of your surgeon on your behalf, say the staff, I'm one of the people that they can use to get that information to the surgeon quickly. Now, what's my background? I am a registered nurse. I started off as an orthopedic nurse on 4 North, which is the unit you will go to. It's our surgical orthopedic unit for the hospital. I spent the majority of my nursing career there before I was offered the opportunity to be in this role. Now, I do have my bachelor's of nursing science from the University of Virginia. Go Hoos go. So when you come here, and if you're in the ortho gym, you'll notice I have a little corner of UVA memorabilia. The other thing I want you to know is I have my orthopedic nurse certification, like any of the nurses on the unit that have taken care of orthopedic patients for at least 2 years on 4 North, they have it as well. If they don't, they are working on it. And basically it means, as we studied a focused area, which was orthopedics and musculoskeletal system, everything, disease processes, surgeries, treatments, all of that. And then we took a test that was honestly, I feel, harder than my original nursing boards. And if we passed, we got the certification. And to maintain and keep this certification, we have to continue our education on orthopedics and take care of orthopedic patients. Now, when I was talking to you about I'm your resource, I want to make sure that you have my contact number, which is 757-984-7234, and my email address is cgholt1@sentara.com. I work Monday through Friday. I'm off major holidays. If I cannot answer my phone because either I'm not at my desk or I'm working with patients, leave me a message and I'll get back to you as soon as I'm available. Now, why did we ask you to take this class? We want you to be prepared. We want you to know what's going to occur. So I'm going to go over briefly how to understand your procedure, how to prepare for surgery, what to expect during the hospital stay, the physical occupational therapy, pain management, role of the caregiver, as well as transition planning. Now, we call this class a FUD class. Basically, it was created to relieve fear, uncertainty, and doubt. So my goal is to help relieve any anxiety that you may have, because most people end up with anxiety when they're going into the unknown. Say that you've never had this surgery before, you have no clue what to expect, or if you've never had surgery here at our hospital. So hopefully you will find this class very helpful. Now, Centera offers what we call the Centera Ortho Joint Guidebook. It is an excellent source of information regarding your surgery. It answers frequently asked questions, as well as gives you checklists on how to prepare for surgery that I'm going to talk about in this PowerPoint. The other thing is, a lot of patients find it very beneficial. So where do you get this guidebook? You can check with your surgeon's office to see if they have copies of it. A majority of our surgeons' offices get them from us. So if they don't, go ahead and give it to you. You can ask. The other thing is, I will check with you when I talk with you. I will provide an electronic PDF copy until I see you in person and can give you the physical, actual book copy. So it may be that you don't get the actual book that you can hold in your hand until you're here for surgery, but I can provide the electronic, the PDF copy, by sending it to you through email. Now, we want to make sure you have that guidebook when you're here at the hospital. So if you do get it ahead of time, the physical book, please bring it with you. If you do not, I'll check to make sure you have one when you're here. Now, again, I said I was going to go over briefly the procedure. I'm not going to go into any gory details. I'm not going to show a video of the actual surgery. So the goal of your surgery is to lessen the pain and restore the function. You may be bone on bone, which means you have no cartilage, giving you cushioning, so that causes quite a bit of pain when you're walking. The other thing is, you may have brittle bones, arthritic bones that need strengthening. So what your surgeon is going to do for a total knee replacement is remove any of the damaged bone and cartilage from your femur, tibia, and kneecap, and then they will insert an artificial joint, also known as a prosthesis. So they go down here to the bottom of the femur where it looks like it's got the metal cap over the bone. They shave the bone down to place that piece of the prosthesis over top of that to strengthen the bone, and then they go down to the top of the tibia and again cut the top off of that to strengthen that bone and put another prosthesis in there. And then they put a polymer, which is the white lining here that you're seeing, that acts as your cartilage. It gives you that cushion that you need so you're not bone on bone or prosthesis on prosthesis rubbing up against. The other thing that they will do after that's done, they actually take a disc of polymer and they put it behind your kneecap so that is not rubbing up against the prosthesis or your bone. Now, when it comes to a total hip replacement, same purpose. They will remove any of the damaged bone and cartilage from your femur and pelvis with an insertion of an artificial joint, again, the prosthesis. So they're going to the top of your femur this time. They're cutting off the femoral neck and head and drilling a canal down in it to place the prosthesis arm that goes in. And then they go over to your pelvis, to that socket, and they will clean that out, shave it down, and then put a cup that has a polymer lining in it that acts as your new cartilage, again, giving you that cushioning so that you don't have that pain when you're moving and walking around. And we do want you to know, when it comes to this is a hip replacement, a knee replacement, or revisions. those are considered elective surgeries. They're not emergency surgeries. So you do have to get medical clearance. What does it mean to get medical clearance, though? You have to see your primary care. And what happens is that primary care doctor is going to make sure if you have any medical issues that they are controlled. So if you have high blood pressure or diabetes, that those issues are under control. And they may also suggest if you have a cardiologist or a pulmonologist or nephrologist for certain conditions that you normally see, that you may have to go follow up with them too for clearance. Because say you have end-stage kidney disease, we need to make sure your kidneys are working at a proper rate, or that your lungs can withstand any of the anesthesia after or with the surgery. So we want to make sure you are the healthiest you that you can be for your surgery. Now, I am not the only person that you will speak with here at Centura Williamsburg Regional Medical Center. You will receive a phone call from a pre-admissions nurse. What their job is to do is they go over your health history and medications, and they will direct you on what medications you are allowed to take before surgery and what medications you should stop. A lot of times, some of the medications they'll ask you to stop would be NSAIDs, also known as anti-inflammatory type medications. So what happens with that is it can cause some issues with your surgery. So they'll tell you, please stop 10 days to 2 weeks. So think about meds such as ibuprofen, also known as Advil, prescribed Celebrex, things like that. Now, if you're taking an aspirin every day, so you're taking an 81 milligram aspirin that's scheduled, not for pain management, then they'll tell you to find out from your doctor when you can stop it. But say you're taking aspirin just basically for pain management, and typically you're taking it probably more than once a day whenever you're having pain. It's not something you routinely take. Then you're going to need to stop that. But if you forget what medications they've told you to stop taking or which ones you're allowed to take, they do provide their number to you so that you can call them back and ask them. They're there to help you with that. The other thing is they may talk to you about other medications that are over the counter, such as herbal medications, vitamins. They do need to know those as well, because some ones you are not allowed to take before surgery. The other thing is they're going to go over eating and drinking instructions, and they'll talk to you about any lab work that is needed. So they do have a little bit of a conversation with you, and they are one part of our program that really helps the function of everything to go smoothly, at least. Now, the day before your surgery, you're also going to receive a phone call from another department in our hospital. They will call you the business day before your surgery. So if, say, the day before is a holiday or it's the weekend, then they'll call you the business day before that. So they'll call you between 2 and 4 p.m. to tell you when you are to arrive to the hospital for surgery. They'll also review those eating and drinking instructions, and they'll go over the scrub, the pre-wash that you're going to need to use the night before and the morning of your surgery. They're going to tell you to have clean sheets on your bed. And then gather all your stuff, make sure you have clean clothes to go to sleep in, clean linens to dry off. Take the scrub that we provide, because we do provide you with the scrub. You can either check with your surgeon's office and see if they have it there, because I do provide it with them with the written instructions, or you can come here to our hospital in Centura and grab it at the front registration desk where you check in to do lab work. So again, that night before surgery, when you're getting ready to take your shower, make sure you have the clean linens on the bed, that you have clean clothes to get into after your shower, and of course, clean towels to dry off with. Take the bag that you have the scrub in. You're going to take half that bottle and 2 washcloths to do that type of shower. But we do advise do your regular shower first. If you need to wash your hair and take care of all the major areas, your routine, please do that before you use the scrub. After you've done that normal bath, you will take that scrub, put it on the washcloth. You're going to lather it up, turn the water off, lather it up all over the skin. The only areas that we ask that you do not put that scrub on is your face and your hair, and then your private areas. After you've got that all lathered on the skin, you let it sit for 5 minutes before you rinse it off. So 5 minutes can be really long when you are naked and cold in the shower, in all honesty, so you're going to want to have a timer or have somebody timing you while you're in there. After the 5 minutes is up, again, you rinse it off. You will dry off with a clean towel and then get ready for bed. Get those clean clothes on. Now, do not use any lotions on the skin afterwards or any sprays, perfumes, anything like that. You are allowed to wear stick deodorant. And when you're doing your showers, we do want to remind patients, please do not shave your operative leg for at least 48 hours before your surgery. We will take care of that when you are here at the hospital for surgery. They will shave that leg. And the reason we ask that you don't do it in your home setting is because if you nick the skin, there's a chance that you can get bacteria into that. And we're doing everything that we can to help prevent you from getting an infection after your surgery. Now, when it's time for you to actually go to bed that night and you're getting in your bed with your clean linens, we do like to remind patients you are not allowed to sleep with pets. So please do not let them get in the bed with you because they carry bacteria on their coats. You are allowed to have your spouse or significant other sleep with you. There's no reason to kick them to the couch that night, but we do recommend, of course, that they, shower and do their regular shower, their own stuff. They don't have to use scrub, but just regular shower and put clean clothes on before they get into bed with you. Now, another thing that we like to remind patients is you should not drink alcohol or smoke the night before your surgery because it can affect the anesthesia. They will, when they do that phone call, the business day before your surgery, they'll also review those eating and drinking instructions with you. Now, there's one thing that not all hospitals do that may sound a little weird to you, but we will tell you that you should drink 8 to 12 ounces of Gatorade 2 hours before your arrival time to the hospital. This is to help improve post-op recovery. It helps with nausea and vomiting and issues like that occur after surgery. But just remember, you are following their instructions that they give you the business day before on when to stop eating solid foods and when to stop drinking liquids and the Gatorade instructions. Now, the day of your surgery, before you leave your house, you're going to take the second shower with the scrub, just like you did the night before. Then, when you get to the hospital, we want you to know you come in through the main entrance of the hospital. We suggest leaving your belongings in the car, in a locked vehicle. A family member can grab it once they know your room number on the nursing unit to bring, so that your stuff isn't just sitting out in the open at the hospital. Now, when you come in through the main entrance, we want you to stop at the front registration desk, the same area that you check in for lab work, but you need to check in there. If you do not stop there, they do not know that you're here. They may think that you skipped out on your surgery. So make sure you stop at that front registration desk to check in. So that registration desk is behind our waterfall that when you first walk in that you see. It's typically 3 people are sitting at that desk for the check-in. Now, once you're all checked in, you are going to take the elevator to the 2nd floor. And when you get off the elevator, please take a left and have a seat and wait for them to call you in to the prep room. Now, if you take a right when you get off this 2nd floor, it's okay. It's one big circle up there, but to the right is maternity. So you just keep going around the circle if you have made that mistake, and it will get you to the OR waiting area. Now, the prep room. So once they call you back, they've got to get you ready. So with the prep room, the first things they're going to do, they're going to get you in a hospital gown. They're going to check your vital signs. They're going to review your health and medications that you have been taking. Now, something that makes it a little bit easier, because they're going to do this a couple different times while you're at the hospital, the review of health and medications. There's in the guidebook, if you get that ahead of time, on page 12 is a chart that where you can fill out all the medications you're taking. Make sure it's the ones that you're currently taking, even the ones that they may have asked you to stop before surgery, and then anything over the counter. With that medication sheet, you just are going to provide it to them when they're checking you in, and just it makes it so much easier because you may be a little anxious and forget some of the medications that you're taking. Now, you may already have something like this at home, though. I do hear from a lot of patients that's something that they've already done, that they keep in their wallet or they keep in their purse. The next thing that they'll do is they'll establish an IV line in your arm. So with that IV, you're going to have that IV placed for access at all times while you're here at the hospital. They will remove the IV when you're getting ready to leave for discharge. Once that IV is established, they will get an antibiotic ready, and they'll start the antibiotic typically before you go into the OR, if not on the way. Now, that antibiotic is used to help prevent infection after surgery, and you'll get a couple of doses before and after. Now, one of the things that we do is we do what we call an iodine swab in the nose. They do it twice. They do it one time before with your lab work. So with that, the reason is when they swab your nose, they're actually testing for something called MRSA and staph bacteria. Now, it doesn't mean that you have an active infection if it's positive. It just means it's colonized, it's hanging out in your nose, and they want to make sure they put you on the right antibiotic if you have those to protect you against it. Now, the second time they do it the morning of your surgery in that prep room to just clean your nose, because of course our noses, they carry a lot of bacteria. It just hangs out up there, so we want to just protect you as much as we can from an infection. Another thing that the nurses will review with you is the pain scale. Pain scale is 0 to 10. 0 means you don't have any pain at all. 10 means the worst pain possible. You're crying. You've never had this much pain. So we want you to be honest when the nurse asks you, what's your pain level? We do read body language, so if we ask you what it is and you tell us it's a 2, but you're crying, you look like a 10, we're going to ask you, are you sure that's your pain level? That's not how you appear. The other thing is, I have had some patients in the past when I'm asking them their pain level, they'll shout out or say, you know, my pain level is a 24. I understand, or we understand that your pain is very high, but for charting purposes, we can only put up to a 10. But believe me, we're reading your body language. We can see that you're in a great deal of pain. but we hope that's not what you'll be dealing with while you're here in our hospital. Now, meet the anesthesiologist and the surgeon. So this is just talking about when you're in the prep room, you're going to see your surgeon and you're going to meet your anesthesiologist. What they're going to do is review your health and medication history. Again, they're going to review any nausea and pain management concerns and what medications they're going to use for that. They're also going to review your choice of anesthesia. Typically what they offer is general anesthesia or spinal anesthesia. With general anesthesia, you know nothing at all. You're completely knocked out. They may have a tube down your throat breathing for you. With spinal anesthesia, you're not knocked out completely. What happens is they numb you below the waist and you're awake, but they will give you medications such as propofol that basically puts you off in la la land. You don't care about what's going on. You have no clue what's going on. You're off somewhere else. So after the surgery is done, they dial that kind of medication back, and you come to you're more awake and alert compared to general anesthesia. Now, they will talk to you about your health history, and that can also determine what kind of anesthesia you can have, because some patients say you have had major surgery on your spine or you have some kind of spinal issues such as scoliosis that you may not qualify for spinal, or say with general that you're somebody that's hard to intubate or you've gotten really sick with anesthesia that may lean you more toward getting the spinal. So that's why our anesthesiologist will talk to you, and they don't get your consent until that morning of your surgery. And they will really go over it with you. So if you don't understand or you have no clue what they're talking about, stop them and say, hey, please explain it to me. Because I always say you need to be informed before you sign consent. Now, the next thing that we're going to talk about is for total knee replacements. Majority of our surgeons use nerve blocks. Now, I'm not talking about this like the spinal anesthesia. I'm talking about nerve blocks. It's completely different. So what a nerve block is, it's a single injection that's done before you go to the OR to help with post-op pain, and it's done in the leg. They have two types, a femoral nerve block and a adductor canal block. Both of them, what it does is it numbs the pain sensories in that leg, and it can also numb or block out the motor sensory briefly. So when you wake up, they're going to ask you, you know, how are you feeling? You may say, oh, I don't feel my leg at all. That's normal. Don't freak out. They're also going to start asking you, doing their neuromuscular assessment checks. So the nurse may say, can you please do a straight leg raise or lift your operative leg on your own? And you say, yeah, no problem, I can do that. Well, when you go to lift it, your mind's telling you, sending those signals to your nerves to lift that leg up to the muscles, and nothing happens. That's normal. That's where that motor sensory is being blocked from the nerve block. So don't freak out. What will happen is they will put you in what we call a knee immobilizer when you need to get up. And again, this is only temporary. It will wear off. Sometimes it takes a couple hours. Other times I've seen 24 hours. Everybody's different on when it'll wear off. But remember, it's temporary. So when you go to get up, they'll ask you about doing the straight leg raise. Until you can do a straight leg raise on your own, they will use the knee immobilizer. It basically does exactly what it sounds. It prevents your knees from buckling, from moving when you're up and walking. And we want that when the nerve block's in effect, because what the nerve block does, it affects your quad muscles that control the knee. Now, I have two rules that I like to talk about briefly at this point. You are a high fall risk after you've had surgery. With that, we color code all of our patients that are high fall risk with yellow. So you may notice that you've got the yellow gripper socks on. You may have a yellow band that says fall risk. So what that tells everybody is you are not allowed to get up on your own at all. The entire time you're here at the hospital, you cannot get up on your own. It has to be a staff member. It cannot be a family member. And we do put bed alarms and chair alarms on that will let us know if you do try to get up without our assistance. Please do not argue with my staff because it is for your safety. We do not want you to fall. If you fall, you could break something, including the bone around the prosthetic. So please, please, please do not get up on your own. You need to use the call bell. And they will go with you when you go into the bathroom. When they go to get you up to take you to the bathroom, nursing staff should be staying with you in that bathroom because that's where most falls can occur. The other rule that we have here that I ask that you do not argue with the staff is we use a gait belt that is wrapped around your waist that anytime you go to get up. It's a small gait belt. It creates a handle for us to hold on to anytime they go to get you up, walk you in the hallways, walk you to the bathroom. Basically, if anything happens, we can grab onto that gait belt. Say you're starting to feel like you're going to faint or you're lightheaded. We grab that, and it helps us maneuver you. It either gets you back into the chair, to the bed. If you're nowhere near those items, if we have to lower you to the ground safely. But it's very important that that gait belt is used every time that you get up. Now, once they move you from the prep area and the holding area, they will take you to the operating room. Just so you're aware, the operating room is cold, and they typically do that to help with sterilization and preventing the spread of any kind of germs. But you don't have to be uncomfortable. You don't have to be down there freezing. You can ask for a warm blanket. Now, they will do your surgery on an operating table after your surgery is completed, which takes anywhere from an hour to an hour and a half. After that's done, they'll move you into a hospital bed. And once it's completed and you're on the hospital bed, they move you over to what we call the recovery room, also known as PACU, which is typically a 1 to 2 hour stay. A nurse is watching over you to make sure you're awake and alert, that your vital signs are stable, that your pain is under control. They'll offer you pain medicine if they need to, any nausea medications if you're nauseous. They'll also start doing those neuromuscular assessments, the checks that I was talking about earlier. So besides raising your leg, they're also going to squeeze the toe on your, or at least one toe on your operative leg, and check for what we call capillary refills, which basically means you're getting all the blood perfusion down in that leg. They'll also check for pulses in your feet. They'll squeeze the nail bed to your hand up just to check again for the blood perfusion, and they'll stick a oxygen sensor. So with that, I like to let my patients know, please, if you have toenail polish or fingernail polish on, make sure on that operative foot that at least one toe, and it's preferable the big toe, but whichever one you like, that there's no fingernail polish, or at least it's a clear coat so that we can see the nail bed. And the same thing is for a finger on any hand for the oxygen sensor and to, again, assess the nail bed. I just want to remind you that we cannot make the pain go completely away. Hopefully your surgeon did not tell you this is a pain-free surgery. The pain is going to be different than what you've experienced. It may be less than what you were dealing with before. Some patients tell me, oh, this isn't bad at all compared to, what I was dealing with on a daily basis. Our biggest goal here is to keep you safe and successful. So we aim to manage the discomfort so that you can eat, sleep, and move around. Now, after you are moved from the recovery room, they will take you up to the orthopedic unit. Again, that's 4 North. And our rooms are all private. So you do not share a room with another patient. And each room has its own bathroom. It has a little couch along the window where your visitor can sit. It will have a TV, a little desk, a little closet. It also will have what we call an orthopedic reclining chair. The one that's pictured in the bottom corner here to the right is not the actual chair that's in your room. It'll be a blue chair. It was specifically made for patients like you. Now, you will spend a lot of time in that chair. After your surgery and you're up on 4 North, they're going to try to get you into that chair as quickly as possible because we don't want you spending all day in the bed. The only time you should be in your hospital bed is for sleeping at night. The reason why we want you up in that chair as much as possible is because it is known that your recovery is a lot faster and smoother if you're sitting up versus laying down, and it helps prevent pneumonia after your surgery because you're able to expand your lungs better when you're sitting up. Now, post-op activity. So this is just wants to tell you some little things real quick to expect. Again, like I was talking about, you'll get out of the bed to the chair as quickly as they can as long as you're stable. Nursing staff, if you're in the bed that you haven't gotten up to the chair, you're sleeping that there at night, they're going to put a pillow or a towel roll underneath your ankles to prevent your heels from touching the bed because that's where a lot of pressure injuries come out of. The other thing, though, I want my knee patients to know is you are not allowed to put anything under your knee, that operative knee, after surgery except during physical therapy sessions because there's an exercise in there that requires the rolled towel under the knee. And the reason behind that is if you keep your knee in that kind of position with something underneath of it for a prolonged period of time, it can cause your muscles to tighten. It can lead to scar tissue. So we really don't want you to do that. We want you to get that flexion and range of motion you were intending to get after a knee replacement. Now, coaches. What is a coach? Coach is typically your caregiver, family member, or friend that is there for you for when you have your surgery, for when you go home. We encourage them to also be a part of the pre-op education. We also encourage them to be involved with your transition planning. Now, when it comes to physical therapy, we typically would allow a one visitor or that coach in the gym with you, but things may be different. I will specify that when we talk on the phone. Now, when it comes to visitors, when you have that one visitor that day, if they're not considered your coach, not involved with your care, we do ask that they do not come in while you're in group therapy. And group therapy is between 10 to 11 and 2 and 3 p.m. on average. And again, things vary. It may be a little bit different, but nursing staff will let you know what time group therapy is. So we ask that the visitor does not come into the gym for that. If they come while you're here for group therapy, they can just sit in your room and wait for you to come back. Now, I'd like to warn my patients, we do get you up early in the morning. Typically, nursing staff will wake you up between 4:30 in the morning to 6 a.m. And the reason behind that is your surgeon has ordered lab work, and they want the results by the time they come in to see you. Nursing staff also needs to check your vital signs. They're going to offer to get you cleaned up in the morning. It will either be done with comfort wipes, also known as bath wipes, or the water basin. So let the nurse or the nursing staff know what you prefer. And you can also tell them, hey, I don't like to bathe in the morning. I prefer to bathe at night. We just let us know so that we can find out what your preference is. Some other things that occur in the morning is group therapy and individual therapy. They should be rotating out your ice patch and checking on your pain as well when they first get you up. Now, we want to welcome you to the Ortho Joint Center, which again is 4 North. Once you meet your nurse and she does your admission, she's going to review some things. She's going to orient you to your room. She's going to show you things such as the call bell, fall mats. She's going to have your bed alarm on or your chair alarm on. They're going to talk to you about how to prevent skin breakdown. They're going to review an SWRMC, which is the blue breathing device that is used to help prevent atelectasis after surgery, which leads to pneumonia, and so we don't want that, so that's why we use that SWRMC. The nurse is going to monitor your intake and output, so how much you're eating and drinking compared to what is coming out urination-wise and bowel movement-wise. Now, other things, vital signs, of course, they'll be checking your vital signs. They will check them frequently in the beginning. When you first come up to the unit, they'll check your vital signs every hour for 4 hours, and then it's every 4 hours for the first 24 hours, and then they just go to whatever the doctor orders after that. Other things that they'll do, each change of shift, a nurse will do a head-to-toe assessment, just checking over you completely, not just your leg. Now, change of shift is it starts at 7 a.m. for day shift, and then night shift comes on at 7 p.m. So our nurses work 12-hour shifts. So I suggest to my patients, make sure that if you need to potty or if you need pain medicine or any kind of assistance, try to get that done before 6:30 in the evening and the AM, because of when change of shift occurs. It's very busy at that time when the nurses are trying to get report and they're doing their huddles for oncoming shifts. Now, another thing is your home medications. Again, we talked about in the guidebook on page 12 where you can create a list, or you may already have a list of what you currently take. When they do their admission process on the nursing unit, have it out so the nurse can verify with what they have in the computer. And know that you do not need to bring your medications with you to the hospital. We have a pharmacy that has, well, it's a large pharmacy stocked very well. The only one that I've been told that we should advise patients to bring in is if you use glaucoma eye drops. If you use those, bring them in because they are very formulary specific, and we just may not carry that brand at the hospital. Now, all other medications we typically have. If there's any chance, say we are out of stock of a combination pill or something like that, pharmacy lets us know pretty early on. They may even call the nurse in the middle of the admission to tell her so that she can let you and a family member know to see if it can be brought in so that you're not missing taking that medication while you're in the hospital. Now, pain management. I really like to review this because I really want y'all to be aware ahead of time, because when you're here at the hospital, when it comes to narcotics, it makes you a little foggy-headed and forgetful. So if I start telling you now, you're going to know what to expect. Now, we use different types of different types of pain control methods here at our hospital. What they will use is based off of your health history and your doctor's preference, and he is the one, your surgeon is the one that will order the pain medication for you. Now, what are the methods that we use? Of course, we use oral pain medications, so pills, once typically throughout after you're done in the OR, they start really trying to push you towards the oral medications because you cannot go home with IV medications. They do have IV pain medications ordered, but what they're typically used for is what we call breakthrough pain. Say they gave you the oral pain medicine the doctor prescribed you an hour before group therapy, and you come into the gym for group therapy, and we ask you what's your pain level, and you tell us it's a 9 or a 10, you're crying. We're going to be contacting your nurse and asking, is there something else that you can give this patient that will act quickly to help get them through therapy? Now, typically when you're taking oral pain medicine pills, it takes 25 to 45 minutes to take effect. So that's why we always hope that you're given your pain meds an hour before coming into group therapy. Other ways that they do help with pain management, of course, is the nerve blocks for our total knee replacements, and ice. Ice is going to be your friend while you're here in the hospital and when you go home. So we're going to encourage your ice packs to be changed out frequently. One thing I do want to mention when it comes to the IV medications is we do have one IV medication that is pain medicine that is not a narcotic. It is what we call Toradol, and it is given to help patients through some of the pain when, say, you're just the oral narcotics are not helping, or if your blood pressure is too low or your respiration rates are too low and they cannot give you a narcotic, they'll use the Toradol. We highly encourage that use as long as the doctor's ordered it for you. Not all doctors can order it for patients. Patients that are having kidney issues would not have that ordered because it can be a little bit harder on our kidneys, and you can only get so many doses of that medication. Now, when it comes to oral pain medications, what I specifically am going to talk about are narcotics. Remember, when it comes to narcotics, they can only give it to you when it's safe. So the nursing staff will check your vital signs if your blood pressure is too low, if your respiration rates are too low, then they cannot give you a narcotic. Please do not get mad at the staff when they tell you they can't because of the issue. Because what happens is narcotics decrease your drive to breathe, so which causes you to have lower respiration rates. The other thing is it actually can lower your blood pressure. And so we don't want to further lower your blood pressure. Say you're 85/40. Sorry, we don't want to make you any lower because that can be dangerous. Now, when it comes to oral pain medication, they can be taken every 4 hours as needed, and that's how the doctor typically will have them ordered. And what we mean by as needed, it is not scheduled for the nurse to automatically to bring it to you. So when you know you're due for pain meds again, please hit the call bell and let the nurse know. Now, the call bell has a button on it that says pain that will specifically send that message to the nurse. Some nurses will automatically know and try to keep track when you're due again and come and check on you and ask for your pain level, but that may not necessarily happen. So I encourage my patients to really pay attention and know when they can have their next dose of pain medicine. And hopefully it's timed out to where you get it an hour before you go to group therapy. Now, when it comes to narcotics, they can also cause drowsiness. So you may notice that you feel pretty sleepy after you take them. The other thing is they are known to cause constipation. So your surgeon will have ordered you some form of a stool softener or stimulant to help prevent constipation. And those medications may be Colace or Miralax. Those are over the counter, and we do encourage you to continue to take those when you're discharged to wherever you go next after you're here at the hospital, just to help prevent constipation while you're taking the narcotics. Another thing that your doctor will order is an anticoagulant, also known as blood thinner. The reason behind that is anybody that has a surgery in a lower extremity is at risk of a blood clot, and so they want to prevent that. Now, which one that the surgeon orders is based off of your health history and their preference. Say you're already on Xarelto because you have a history of AFib, then they will put you back on that. And you will resume it like you were normally taking after your surgery. If you don't normally take an anticoagulant, then it's only ordered for about a month after your surgery, because that's when you're at your highest risk for a blood clot. When it comes time to leave and they're setting up your discharge medications, there's some things that you should really know. You have options. You can have your prescription filled here at our outpatient pharmacy, or you can have it filled at the pharmacy of your choice. Just let your nurse know where you want to have it filled, and they will ask you when you're admitted. We do have a service here with our outpatient pharmacy called Centera to Home. It's where our outpatient pharmacy delivers your medications at discharge to your room. They do accept all major insurances through our outpatient pharmacy. Your copay should be typically the same that you would pay at Walmart or Walgreens. There are some issues that we have, well, not issues, I'll say it's a little bit different for TRICARE insurance. What happens is TRICARE may charge an off-campus fee, and I'm not sure how much that is. Now, when it comes to VA, if you're a patient that's having your surgery done through the VA, that they're the ones covering it, they don't allow us to fill the pain medications here. So it may be, if you're going to get them done here after your surgery, that you may have to pay out of pocket. I've been told that if your surgeon orders it ahead of time, and not all surgeons can, but if they order it ahead of time, you can take that prescription to your primary care and explain to them what's going on to see, so that they can switch it over into that, under that primary care's name, and then have it filled at the pharmacy at the VA, but that does take time. So make sure your surgeon's office is aware that you're a VA patient, just so that everything is set up, because you also will need to, if you're gonna get if you don't have a rolling walker, which you will need, they have to do that ahead of time as well, send that order over to the VA, so that the VA's DME company can provide that walker. Now, when it comes to rolling walkers, again, you will need one after surgery, and a rolling walker is a walker that has 2 wheels on the front, no wheels on the back. And we want that specific type because you're going to be sliding, pushing that walker along the floor. You're not going to be picking it up, because you're going to be bearing weight into that walker as you move, because you're going to be what we call weight bearing as tolerated, or most patients will be weight bearing as tolerated. Some are different based off of the type of surgery they have had, and physical therapy and the surgeon will let us know what that status is. But anyway, when it comes to the rolling walker, if you don't already have one, you can, if you want to check with your insurance to find out if you have a copay. If you have a copay and it's more than $30, you can purchase a walker through our outpatient pharmacy, but it has to be done ahead of time. So give them a call. So we want at least 24 hours, if not longer, notice, so that they can have one waiting for you here when you've had your surgery. Their contact number is 757-984-8100. If you're going to go through your insurance, say you have no copay or it's less than $30, or that's the way you want to do it, you can ask or check with your surgeon's office and see if they will order it ahead of time through the DME company. If they aren't, or they can't, if they don't have enough time, or whatever the issue is, we can do it here through our care coordination, where they will charge through your insurance, and the DME company will deliver the walker and collect if you have a copay from you at that time. Now, there are other things with our outpatient pharmacy that they can provide with you if you think it's any kind of DME equipment, such as a raised toilet seat or shower chair. If that's something that you think you want to get, and most insurances won't cover that. You can purchase it through them. I'm not sure how much they cost, but again, you have to give them time, so you need to call ahead of time. The other thing that they sell down there, it's called a hip kit. It's a couple of different restorative aids, devices. Now, hip kits aren't just for hip patients. Any patient can purchase it. In that kit has what we call a reacher, something that helps like pick stuff up off the floor. It's a long handle with the trigger pull that grips onto stuff to help you get things off the floor so that you're not bending over. It also helps with patients getting on pants. Another thing that they sell in that kit is a longer shoe horn to help you get your shoes on. So again, you're not bending over. It also includes what we call the back sponge. It's a long-handled sponge, so it's more for washing your feet, but you can use it for your back. You can also use it for the top of your car when you're done with it. The other device, the last device that's in that kit, is what we call a sock aid. It helps you with getting your socks on. A lot of patients really like that device. Now, say you don't want all four of those devices, you already have one or two, or you just don't think you need it, you can buy each aid separately. I don't know the prices. They're anywhere from $7 to $9 a piece. But if you want all four, you can save some money by doing it as the hip kit. Now, if you do want to get that, you can just let your nurse know the day of discharge, hey, I want a hip kit. Of course, you can purchase it before your surgery. Say you're here to do lab work, and you're like, yeah, I know, I want to get one of those hip kits. You can stop in at the outpatient pharmacy on your way out and ask them about it. Now, preparing for surgery. So we're talking about how to prepare your home for surgery. Make sure that you don't have anything in your walkway. So remove any throw rugs, any electrical cords, because we don't want you to fall when you go home. And when you're pushing a walker, it's pushing along the ground, so it can catch on things like electrical cords and throw rugs. So make sure your walkways are clear. If you have hand railings, say for your stairs and your bathroom, make sure they are secure, because we don't want you to go grab onto it and it breaks off and you fall. Night lights in the bedroom to the bathroom are very helpful, so you can see where you're walking at night. For frequently used items, we suggest that you have them on shelves or areas between waist and shoulder level. So again, you're not bending over, getting up on your tiptoes to try to get something. Avoid rolling chairs. So we're talking about office chairs, any chairs that have wheels on the bottoms, for at least 6 weeks, because we don't want you to go sit down in them and it moves out from underneath of you. We suggest starting your exercises today. Again, in that guidebook, they have your exercises. For knee replacements, they start on page 24. For hip replacements, they start on page 27. Remember, if you can't, or if you don't have it before your surgery, that guidebook, I can provide it as a PDF copy that I can email to you. Now, when it comes to handicap placards, some patients, you may not have one and you want one for your follow-up appointments with your surgeon. You need to contact your surgeon's office about those. They will provide or they'll help with the paperwork when it comes to that. It's typically a DMV form that you fill out half and they fill out the other half, and then it needs to be sent into the DMV and they will mail the placard to you. Now, what to bring to the hospital? So if you're staying overnight, because your surgeon may tell you, hey, you're going to stay overnight, or they may say, hey, do you want to go home same day? So some things may be a little bit different, but I'm going to talk about as if you're staying overnight. Bring loose fitting clothes. So you want shorts that have like elastic waist bands, things that's loose fitting, because you're going to be swelling after surgery, especially in the operative leg. We also need to be able to access the bandage that's on your leg in case it needs to be changed or anything. So it's something that we need to be able to push up the knee, or pull your pants down a little bit on your hip. We suggest short sleeve shirts, because you'll have that IV line in. If you're somebody that gets cold easily, we do suggest bringing in a light zip-down jacket. Now, when it comes to shoes, say when you're up and walking in the hallways for physical therapy and you don't like to walk in socks on hard floors, so you have arch issues. We do provide those gripper socks, but it's just not comfortable. You can have shoes, but we want shoes that have backing that fit securely on your feet. We do not want you wearing shoes such as flip-flops, Crocs, anything that is not secured on your feet, because we don't want those to slip out while you're walking. Now, you are allowed to have cell phones. Please don't forget the charger, because we cannot provide those. And I do ask patients, when it comes to cell phones, if you're in group therapy or if you're working with physical therapy, please don't use your phone, because it does get distracting and it can hold up your physical therapy. Don't forget that guidebook if you have it ahead of time. If not, remember, I will give it to you. We want you to have it in case you need to reference it while you're here. Now, if you already have a rolling walker ahead of time, you can bring it to the hospital with you, but we will have one in every room for a patient to use while they're here, that they stay here at the hospital and they get cleaned after each patient, but so that that family doesn't have to lug those in and out. But if you are adamant or you want to use your walker, you are allowed to have your own walker here. Now, if you use a CPAP, say you have sleep apnea and you use a CPAP, we do ask that you bring it with you to be used while you're here at the hospital. If you don't have enough distilled water, you don't have to worry, we will provide that. Another thing that I ask patients to bring in is if you have an advanced care plan, also known as a living will or a medical directive, that you bring a copy of that in so that we can make sure it's on file here at the hospital and make sure it's the most current copy. Now, the day of your surgery, physical therapy wants you to know a couple of things. If you arrive to the nursing unit before 4 p.m., physical therapy will see you the day of surgery to do their evaluation, as long as you're medically stable. Now, the physical therapist is going to verify that you're medically stable, that the nurse has done their initial assessment. They're going to check and see what your pain levels are before they start with you. The first thing that they'll do is, get you to the edge of the bed and start reviewing how to get in and out of the bed, getting up and walking with the walker. They're going to try to get you up in the chair. And they will also, they'll start asking you, hey, do you want to walk to the door? Do you want to try to walk out to the hallway? They'll review things that they want you to do throughout the day, such as ankle pumps. But again, they will do all that with you as long as you arrive on the unit before 4 p.m. and you're stable. If you arrive on the unit, to the nursing unit after 4 p.m., they cannot see you. They'll do that assessment and everything the following day. Now, when it comes to getting up in the chair, though, nursing staff can get you up in the chair even if PT hasn't seen you, to just promote being up. And of course, you have to be stable, though, before they'll get you up. And they should be encouraging you to do ankle pumps as well. Now, in this picture, I want you to look real quick. You will see this gentleman has the knee immobilizers on, so you can actually see what they look like. But he has one on each leg because he did both of his knees at once. Now, so again, physical therapy, they want you to remember, the first thing they do with you is the evaluation. They'll ask you things about how many stairs do you have at home, how high is your bed, what side of the bed do you get off or get out of, things like that. They'll also start reviewing some of the exercises maybe, and then your precautions. Now, they're going to review how to get in and out of the bed. based off of what you tell them you normally do at home, and then they'll also start reviewing how to get in and out of a chair safely. They'll review how to safely use the walker and walking around. They'll measure your walking distances. We do have a goal that you walk 300 feet in one setting, so one lap around the nursing unit. They'll review stairs. They'll show you the technique on how to get up and down stairs. It doesn't matter how many stairs you have, it's the technique in getting up and down the stairs. You may not have any stairs at home, but we still also want to make sure that you can go up and down the stairs, because you don't know, say you end up having to go out of the home or something and need to do stairs at some place that you're visiting. They'll review those exercises. They'll also provide the nice ice-cold ice packs after they're done working with you. They, again, really help for pain and swelling. Now, occupational therapy is something separate from physical therapy. If that is ordered for you, they will not see you until the next day after your surgery. Now, the occupational therapist, what they do is they do an evaluation, and they're showing you how to do, regular activities of daily living, such as bathing yourself, dressing yourself, functional activities for after surgery, because you may have already had difficulty before, but then how to cope with your hip or knee replacement. They review those assistive devices such as the reacher, the sock aid, but it's up to the surgeon whether or not you need that. They'll put the order in. Not every patient needs it. A lot of times it may be somebody that, as I've said, had already struggled before their surgery with dressing themselves or bathing themselves. Now, joint precautions, I know I briefly talked about that. They will be reviewed individually with each patient because everybody's different. Majority of patients are weight bearing as tolerated, but some patients are a little different, so they will let you know what you're allowed to do and what you shouldn't be doing. The occupational therapist will recommend assistive devices that will help prevent you from having issues with your joint precautions. So say they don't want you bending over more than 90 degrees, then they'll say, hey, you may need this reacher to help you get stuff off the floor. Now, when it is time to go, what are your options when you leave the hospital? We have a couple different options, and We Assist will help you with those options, but I do ask my patients, please start getting a general idea on what you want to do and have that conversation with your surgeon. You may want this one, which is going home with home health. And with home health, we're talking about physical therapy. You may also have home health nursing ordered. I will tell you, when it comes to leaving the hospital, going home is our goal. Not everybody will get that goal, but that's where we strive for you to go home and heal. Now, the other option, if you're going home, you may be going straight to outpatient physical therapy. That's, again, something that you should be talking with your surgeon about, because that appointment should be set up ahead of time from when they know your surgery is, so that they'll set it up the day after you leave the hospital, or a couple of days after your surgery, because you may only be spending a night at the hospital. You may be somebody going home same day, and so we really encourage, if they want outpatient physical therapy, that you schedule it ahead of time. Now, subacute rehab, also known as skilled nursing. Some patients may need to go there, and typically the reason behind that, or the need behind that, is it's not safe for you to go home. Physical therapy may tell you, you live alone, you're not getting around as good as you should be, before we like to release you to home. So you still need to get 2 sessions of physical therapy every day at a facility. When it comes to going to a skilled nursing facility, your insurance deems where you can go, and we have to wait for the authorization before they can send you. Another thing that may influence where you can go is based off of the bed availability. Does the facility that you've chosen have the beds open to take new patients? One thing I do like to let patients also know when it comes to home health agencies, it is your right as a patient to choose who you want to use as long as your insurance covers them, that agency. You don't have to go with one company that your surgeon says, you know, you have to go with this company. No, you can use whatever company you would like as long as your insurance covers that company. If they don't, you would be paying out of pocket, and I'm sure that you would prefer that your insurance covers those visits. Now, when it comes to outpatient physical therapy, because a lot of patients, if once you're done with home PT, you will go to outpatient, or you may be going straight to outpatient after surgery. What do you need for it? You need the doctor to write a script that says how often you need to go, and they will send it over to the facility that you have chosen. Now remember, when it comes to outpatient physical therapy, it's your choice where you get to go as long as your insurance covers it. We always suggest you check with your insurance to make sure that they will cover those visits. Another thing that we tell patients when you're trying to figure out where you want to go, first off, make sure you figure this out before your surgery. The other thing is, because we want you to figure out so that you can visit the facility ahead of time. Say you've already gone there and you know what they're all about and that's where you want to go. Say you've never been there, visit, ask. Ask them about what their one-on-one care is like, who will you work with for your appointments, will you work with a physical therapist, will you work with a physical therapist aide or a physical therapist technician. Find out what their team approach is. Now, what can you expect from outpatient physical therapy? The first day, they'll do an evaluation. They're going to want to know what your goals are. They're going to ask you, what do you want to achieve by the end of this? Do you want to get back to dancing or get back out to riding a bike, things like that? They need to know that because they will form an home exercise plan, which is an individual plan based off of your goals. Now, they're going to, talk to you about pain. They're going to advise you to take your pain medicine an hour before you go to physical therapy. They're going to talk to you about the healing time. How long does this look like it's going to take? And then, of course, how much function are you hoping to get after this? They'll review if you're a knee patient, especially, flexion and extension, and go over that with you. Now, home health. So I do want you to know when it comes to the home health decision, if the doctor has ordered home health nurses to come in, they will see you twice a week. If you're having any issues, any concerns, need anything, you are to call your home health agency because they are there for you. They are on call 24 hours a day, 7 days a week. That is another reason why the surgeon has put that in place for you. Now, when it comes to home physical therapy with the home health agency, they will come to your home 3 times a week until you're ready to begin outpatient physical therapy. That typically will happen for a week to 2 weeks. It just depends on how you're doing. Now, there's a couple other things that I would like to talk about with my patients that aren't on the slides. Earlier I was talking about, if you're staying overnight. Some patients are offered the opportunity to go home the same day, and that is dependent on your health history, your age, and your surgeon. Now, if they offer you to go home same day, there are things that need to be done ahead of time to make sure you get out of here that day. First, again, make sure the doctor's office has set you up with a rolling walker if you do not have one. Secondly, if they need to know what your plan is going to be for physical therapy afterwards, A lot of the patients that are done same day, to my understanding, the surgeons are ordering home physical therapy for at least the first week and then going to outpatient therapy. If you're somebody that knows that you want to go straight to outpatient physical therapy, make sure your surgeon's aware of that. But bottom line, when it comes to that, the office should be helping that you get that set up before your actual date of surgery. A couple other things on what to expect or to know. You should be your surgeon's first case of the day if you all have decided that you're going to go home the same day. So make sure the doctor's offices or your doctor's scheduler is aware that you're going to be a same-day surgery so that they can send in a note into our OR schedulers here on how they should put the order in for that surgeon. The thing is, if you're going home same day, you still come up to the 4 North the nursing unit. That's why we want you to be the first surgery of the day, because you need to come up before 4 p.m. so physical therapy can work with you. You still have to meet the same safety criteria to be able to go home. So they're going to make sure you can safely maneuver, walk with the walker. They're going to measure your walking distance. They're going to have you practice going up and down stairs and then practice getting in and out of a car. We have a practice car in the orthopedic gym that patients use to get in and out to make sure that can be done safely. They do adjust it to the height of your car because we want to simulate what's going to happen when you're being discharged. Now, if for some reason, you were planning this to go home same day, but you haven't met that criteria with physical therapy, you may not get to go home because it's not safe. The other things that can prevent you from going home same day is your pain management. Say your pain was not is not well managed. We want to make sure that is before we release you same day. The other thing is we need to make sure you can urinate or void on your own without having to have any kind of catheterization, because we don't want you to get into any kind of trouble when you leave us, because of course one of the side effects of anesthesia, any anesthesia, is that your bladder goes to sleep, just like your bowels, and it takes time for it to wake back up. Well, we want to make sure your bladder's back awake and doing what it's supposed to on its own, that doesn't need any assistance from nursing medical staff to drain the bladder. Now, a couple other things that applies to everybody, each, same day, staying overnight. We have talked about the ice, how ice is very beneficial for swelling and for pain control. Now, we send you home with a blue sleeve and 2 ice packs based off of if you have one joint done, or say you get both knees done at the same time, then you get that set for each knee. Or if, say, you're getting both hips done at the same time. But bottom line is we're sending you home with the 2 gel inserts and the 1 sleeve per joint. And you may be somebody that likes to have 2 packs of ice on at the same time. Like a lot of my knees like to have one on top and then you get one underneath. So you only are going to be given those. Say you don't have anything else at home, you don't have any more ice packs, you can make your own. And I do suggest do it ahead of time before your surgery to leave it in the freezer for you to be able to use, because it takes time for things to refreeze. So I always ask my patient to have at least 4 forms of ice therapy. So the 2 we provide, and then make 2 of your own. There's a recipe in your guidebook where you can take 3 cups of water to 1 cup of rubbing alcohol that you put in a gallon Ziploc bag, and you should double bag it in a second bag. You put that on a flat surface and in the freezer, and it freezes, makes a slush. It does not freeze solid, so it can form to your leg the way the gel packs do. There are other things that you can use, though. I've had some patients take dried beans and put it in a Ziploc bag or pillowcase that they sew shut, or you can use rice that you stick in the freezer, but they stay cold for a long period of time, just like the gel, and they also form to your leg. Now, some other things, or the last thing that or two things, I want to make sure, do not forget to get your pre-op scrub, what you need to wash with the night before your surgery and the morning of. Remember, you can check with your surgeon's office to see if you can grab it from them. If not, you can get it here at our hospital, Centera Williamsburg, at that front registration desk where you check in for lab work and surgeries. The other thing is traveling. After surgery, if you are taking or going on a trip, say you're riding in the car for more than an hour, please stop every hour, like pull at a rest stop somewhere where you can get up and move around and get the blood flowing in your legs. The other mode of transportation, say you're taking a train, well, that you just need to stand up, move your legs, as long as it's not, as long as it's steady and safe for you to get up and walk around, we suggest that you get up every hour and, again, get the blood moving through those legs. Now, if you need to fly, you need to verify with your surgeon first that it is okay for you to fly. And then you need to, if you need to deal with TSA, which you do when you fly, I always suggest my patients to go through the full body scanner. So the platform that you stand on that marks where your feet should go and raise your hands above your head. With that, it pinpoints exactly where the metal is, so that when you come out and they need to check you over, you can tell them when they're patting you, you know, I have a hip replacement or I have a knee replacement. I do know some of the doctor's offices will provide you a card that says you have a joint replacement. The TSA does not care. They're still going to want to check you over. So just be mindful of that. It's better to do that body scanning machine versus an old metal detector, because the older metal detectors cannot pinpoint where the metal is. Now, I don't have really anything else for you. If you have any questions or concerns, please give me a call. I am here for you. If I don't know the answer, I will find out who does and get them to call you. The other thing is, if, say, you need to talk to your past nurse and you forgot her number, I can figure out who it is and get them in contact with you. I really appreciate you taking the time to watch this video. I look forward to meeting you when you come here for your surgery. And again, thank you for choosing us here at Centera. We look forward to being a part of your revolutionary journey.